I'm going to have a presentation on brain metastases and chemotherapy, and as you know, there have been a lot of different drugs introduced now in this field. We do not have very much data about immune therapy, and about target therapy we do have a little bit more, and all the trials coming from chemotherapy are very early on trials with not very much impact. So what can we say? We have a remission rate of around 5 to maybe 10% with photomustine and also with temozolomide. Those are drugs that are partially licensed. Temozolomide in most countries and photomustine in some countries. But they have never shown to show an overall survival benefit. So it's actually a last line therapy of the days today. There is some trials going on in combination with immune therapy for photomustine and ipilimumab, which showed some promising phase 2 data, but this is ongoing now in a phase 3 trial. And there's also some data about the combination of a whole brain irradiation and chemotherapy. And we have to state that there is absolutely no beneficial situation combining these two different options. So basically, last line therapy, or maybe no therapy at all, maybe only salvage therapy, and chemotherapy will not play a role in the future, I think, for metastatic melanoma in the brain. There will be a trial, I think, on adjuvant chemotherapy at ASCO for brain metastases, but it's too early to talk about that now, so you got to wait a couple of weeks, but look out for that one. And there is a little bit of data maybe in regards of chemotherapy, that chemotherapy could prevent brain metastases, but it's very weak evidence. And since we don't apply chemotherapy in order to treat brain mets, it's also not applicable in order to prevent brain mets. And we have much better and stronger drugs coming up in combinations. The main issue is that upfront we should now include patients with brain mets in our trials when we deliver new combinations, because after all, they're not all doing so badly. So we have to pick the right patients in order to get the drugs to the patients with brain metastases more early than now. I would say no, rather save the money and buy for fewer patients something that is worthwhile doing, because also for metastatic melanoma, we have not managed to show survival benefits with just chemotherapy. It was just the only thing that we had, but no survival benefits. So rather for today, although if it's hard, no therapy instead of giving a chemotherapy that is not working. So we need, for these developing countries, we need to find a way in order to deliver the drugs to them, like we do in HIV for the third world countries, to make it more feasible for patients to have access to these drugs.